Yeah. So I just want to introduce briefly Srini to you. Srini is a very crystal clear teacher, passed out from the Shankar Netralaya, where he was a consultant for several years and now has his own clinical practice in Chennai itself. And as I said, very sought after as a speaker just for his clarity of thoughts. Today, he will tell us about diagnostic tests in dry eye. Over to you, Srini.
Thank you, Kuresh. Can you see the slide now?
Perfect.
Yes, yeah. Okay. So basically, we know that there is an increasing prevalence of dry eye in the recent times, and this has interested the pharmaceutical companies, and therefore we now have a lot of products which we can use to treat the dry eye, and therefore the interest in tests for dry eye has also increased. So no longer is it enough just to diagnose the presence of a dry eye, but we also now want to know what type of dry eye we have in that particular patient and what are the changes that are occurring in the ocular surface so that we can try and rationally choose the products that we have to try and match that particular patient's problem. The problem with the tests, however, are that they are not very sensitive and specific. And if you take a test result, it is often an overlap between the normal and the disease type. So we don't have a specific cutoff or marker in many of these tests, and therefore it has been suggested that the more tests that you do, the better you will be able to segregate the dry eye in a particular patient, and therefore the tests are proliferating, and maybe that is why Nikhil wanted me to do this talk on the diagnostic tests in dry eye. So this is the standard slide that we are using now because this is the DEWS-2 report, which is taken as the guideline by most people at the moment. So they said that we can ask a lot of questions, and if this suggests that there is a problem, then we do a questionnaire to document the extent of the patient's symptoms. And then we do these three tests, NIBUT, osmolarity, and ocular surface staining. And if there's a loss of homeostasis in any one of these, we conclude that there is indeed a dry eye. And in order to try and segregate the patient in the aqueous deficiency or the evaporative dry eye part of the spectrum, we look at the Meibomian glands by mammography, we look at the lipid layer by interferometry, and we measure the volume of the tears. So the questionnaire, we can use the DEQ5, we can use the OSDI, we can use whichever one we like, helps us quantify it. And for instance, if you do the OSDI and if the score is less than 13, and this score is arrived at by taking the number of questions that the patient answered out of the 12, and the total cumulative score for each of these questions. And if it's less than 13, we think it's normal. And if it's more than 33, we think it's a severe dry eye. The DEWS-2 has highlighted tear film instability as one of the triggers for many of the problems on the surface. And therefore, they suggest that we do the NIBUT, which involves projecting a grid onto the corneal surface and looking at the distortion. The machine picks up the area of distortion, the time of distortion, and gives you the NIBUT. This is technically more physiological because you're not adding fluid to a fluorescein strip and then putting it on the eye. You're measuring the BUT in the original state. But if you don't have it, of course, you can do the fluorescein BUT. Hyperosmolarity is the other chief trigger. So you have to use a device for this, which most people don't have access to, the tear lab device. And if you put a sample of tears in it, and if the osmolarity goes up beyond 308, it is considered to be hyperosmolar. Or you look at a difference of more than 8 between the two eyes. The tear volume, we have traditionally used the standardized Schirmer test using the standardized paper and using a 5-minute readout on that 30-minute strip with a 5-minute hookup. And although there are several variations, it is a reasonable test provided you do it in a consistent manner. But if you want more quantitative measures, you can actually use a device to look at the tear meniscus under magnification and measure the height of the tear meniscus. Be that as it may, despite all of these tests, ultimately what we are looking for is whether the condition of interest is damaging the ocular surface, because ultimately that's all we are interested in. And that you could look at by doing fluorescein staining for the cornea and using either rose bengal or lissamine green for the conjunctiva. But if you have a slit lamp which has a yellow filter incorporated in it, the use of fluorescein alone will allow you to study conjunctival staining as well. Impression cytology can be done by taking a cellulose nitrate paper and pushing it onto the bulbar conjunctival surface or the area of interest. It could even be the cornea. You get a few layers of cells and you can look at squamous cell metaplasia, goblet cell density, and in the cornea, you can look for the presence of goblet cells if there's conjunctivalization, and there's a classification system that you can use. Because ocular surface damage tends to affect the nerves on the surface, there can be a loss of sensitivity, and you can use the Cauchy-Bonnet instrument. The AGET aesthesiometers are still in trial. They've not yet come out commercially. and the loss of sensitivity may correlate with the extent of damage on the ocular surface. Ocular surface inflammation, usually we use the redness score. The machine can take a picture and then you can compare it to one of these scales that are available, the Efron scale or the CCLRU scale, to give you a grading. But the other measures can be measured quantitatively using the measurement of the MMP9 level. And that is basically done using the Inflammatory device, which is like the Tear Lab, which again is a problem because most of us don't have access to it. Other clinical tools that you can use is the extent of conjunctival staining, which you can detect with lissamine green, and this has been shown to correlate very well with the inflammatory markers in the ocular surface. Conjunctival edema associated with redness is a sign of inflammation, and if you see these lid parallel folds along the outer border of the lower lid, particularly in the temporal region, this is a sensitive sign. This is because when you have a lot of inflammation, the MMP9 cause a dissolution of the stroma, and the loose conjunctiva can then be thrown into folds. We have to look at the eyelid. You can anatomically assess the presence and function of these Meibomian glands, but you can also have devices which do this by infrared mammography, and you can have algorithms which tell you the extent of dropout to quantify it. And you can look at the lipid layer itself. You can either look at it and look at it like this and assess it as normal, abnormal, or extensively abnormal, or you can actually measure the thickness of this layer using interferometry. The expressibility of the Meibomian glands is something you can do clinically by pushing on the lower lid. You can look at the amount of meibum that is secreted, the quality, and the number of glands that are expressing it. And this will tell you some idea about the function of the Meibomian glands. The lid closure is extremely important, not just to spread the tears across the surface, but also to result in tear clearance, and so tear turnover can happen. And if there is a poor lid closure or a lag of thalamus, then there will be excessive drying and hurting of the ocular surface. And that again, these devices can pick up by taking high-speed video photography and looking at the completeness of the lid blink. So if you look at the ideal tests, the ones that we would like should be easily available in all of our clinics, not just in an institute or in a specialized ocular surface clinic. The test should be easy to do using methods that we're all familiar with. They should be reasonably sensitive and specific. And of course, at the end of the day, they must be cause specific. So in a general ophthalmology clinic, this would be a good scheme of things. You could do the OSDI, which is cheap, freely available just to quantify the patient's symptoms. Look at the ocular redness score for the extent of inflammation. Look at a fluorescein BUT, and if you can do this consistently, it does give you valuable information. The fluorescein can also be used to look at the staining. Like I said, if you have a yellow filter, you can use it also to assess conjunctiva. But if you don't have that, don't bother. Just get a ₹1 lissamine strip, and that will help you assess it. Do a Schirmer for the tear volume, and do the Meibomian gland assessment, both by anatomically looking at the glands and by pushing on it to see the secretion. If you have access to these options, then you could possibly make it a little better. You could do an NIBUT, you could look at the osmolarity, you could measure the tear meniscus height, you could measure the MMP9 levels as a surrogate marker of inflammation on the surface. You can study the Meibomian gland anatomy and quantify the extent of dropout, and you can also actually measure the lipid layer level. So ultimately,
sorry to interrupt, doctor, but could you please wrap up in the next minute?
Last slide. So when you basically come to the end of it, you have to make sense of it all. So you look at the BUT, which is a measure of the mucus. You look at the Schirmer, which is a measure of the aqueous, and you look at the lipid, and put it together to come up with a diagnosis of aqueous deficiency, evaporative, or a short BUT dry eye. To this, you add the presence of inflammation, the presence of ocular surface staining, and look for the other conditions that impact the ocular surface. So this would be a reasonable summary of the testing that we can use in a dry eye state. Thank you.
Thank you, Srini, for having well summarized the surfeit of tests that we have available to us. Not everyone needs to go in for all the tests, as correctly said by you. Even simple tools and more use of our staining strips, the lissamine green and the fluorescein, will go a long way. The more you use, the more sensitive you will be, and the more easier you will reach for these strips. If nothing else you do and just use the strips, they are very useful. Thank you. And we'll move on to our next talk on ocular inflammation by Dr. Ashok Sharma. Ashok? Yeah, you're mute. You're mute, Ashok. Yeah.
Sir, I'm not getting that share screen.
Doctor, you can look at the bottom of the screen. Beside where there is written chat, you can see an option called share screen between chat and raise hand. At the very bottom of the screen.
It's a green box, Ashok.
Yes, sir. Now you got it.
You got it. Okay, fine. Yeah, you're fine.
So are you seeing my slides now?
Perfect. Everything is fine. Your volume is fine. Yeah.
Yes, sir. Okay, sir. So my talk is on ocular surface inflammation in dry eye. In recent years, there has been a lot of interest in this area, and that has resulted in a lot of publication during the last decade or so. Dry eye, as we know, is a multifactorial disease, and out of various etiological factors like tear film instability, hyperosmolarity, apoptosis, inflammation, it is basically the inflammation which is one of the major key factors. There is ample evidence in clinical and experimental studies that ocular surface inflammation plays a dominant role in the etiopathogenesis of dry eye. And immune cell infiltration has been shown in the various sites on the ocular surface in these patients. Of various ocular surface like inflammation markers, the T cell activation is a major one. And the T cell activation causes the calcium and calcium binding to the calcineurin. And this calcium-calcineurin nephate signaling pathway is responsible for inflammation. Cyclosporine and FK06 inhibits this one. Cytokines is another important inflammatory marker, and of various effects on the ocular surface, its effect on neurosecretory block is the major one. This disrupts the production of the tears and decreases the quality and quantity of the tears. MMP9, as highlighted by Dr. Srinivas Rao, is very important. Increased levels in dry eye causes the ocular surface damage. This diagrammatic representation tells us the amount of various ocular surface markers in dry eye as well as in the normal surface, particularly latent proteases, active proteases, and cytokines. So these are important for the ocular surface damage. In addition to these, even the nerve damage is important for ocular surface inflammation. It has been observed that the tear cytokine levels, they have direct correlation with the density of the immune cells, and they have inverse correlation with the corneal nerve density. In other words, the corneal nerve dysfunction induces the immune-mediated inflammation, and vice versa is also true, that the ocular surface inflammation can cause nerve damage. Once inflammation occurs on the ocular surface due to any reason, intrinsic or extrinsic, it enters into a vicious cycle. Surprisingly, ocular surface inflammation not only causes damage on the ocular surface, but also it increases the cytokine levels in the aqueous, which can result in the cataract formation, glaucoma, or even it can damage the endothelial cells. Now, in the beginning, the ocular surface inflammation is there, but the ocular surface may be normal. But with the persistence of the inflammation, it can cause SPK, it can cause persistent epithelial defects, limbal stem cell deficiency, and then even keratinization. And the treatment options will also depend according to the stage of the ocular surface damage. Like initially, immunomodulators may be helpful, but when the epithelial breakdown is there, we may need like autologous serum or amniotic membranes. And later stages, even limbal stem cell transplants or lid margin mucous membrane grafting may be required to decrease the inflammation. Of various symptoms, it is the pain which is very important, and pain equates the inflammation. This is one example of such patient who had severe dry eye and was on regular follow-up with us. One fine day he presented with bilateral epithelial defects which appear to be neurotrophic. We gave him all the medicines to promote epithelialization, artificial tear drops and autologous serum and everything. Contrary to expectations, after 10 days or so, instead of improving, he worsened. And the reason was that he used topical anesthesia frequently to take care of the pain. And he was himself an optometrist, knowingly all the complications. So we had to go for AMT and all that stuff. So this is how the ocular surface inflammation can damage the ocular surface. As pointed out earlier by Dr. Rao, MMP9 is a major marker and we can quantify it. And after quantifying, we can also use it as a marker for deciding whether this patient can be put on immunomodulation or not. Like non-invasive procedure like impression cytology is another one. Whatever measure we may use for the treatment of dry eye, all these have anti-inflammatory effect directly or indirectly. But some of these like corticosteroid, tetracycline, they cannot be used for long periods, and probably topical cyclosporine is the one which is useful. Recently, several other molecules are being evaluated. Trehalose has anti-inflammatory effect and antiviral effect, and that's the reason it has come into talk in COVID-19. Liftigrast is another drug which has got like FDA approval and is being used in USA for treating the dry eye. We have more experience using the cyclosporine A. The problem with this drug is that this drug is not water soluble, but most of the preparations we get in the market they are aqueous preparations. And oil preparation is basically very irritating, and although it provides higher levels. This is one concept which is important for these kind of drugs, that if you have higher PC, that means the concentration in oil phase is more at the interface, then the drug can be effective at a lower concentration. So for topical cyclosporine, we need something like oil in vehicle emulsion. And there is a preparation which has got similar preparation, and one drop of this preparation releases 75 million droplets of one drop. And because of this preparation only, this has very high level at the interface and is effective at the low concentration. Now, topical cyclosporine can be used in several clinical situations to decrease the inflammation in chronic patients. In Murray's ulcers also, we can use it as an adjunct treatment. Topical cyclosporine can also be used for VKC patient with vernal ulcers, or we can use for adenoviral keratitis. This is one patient who had severe rheumatoid arthritis and had perforations. We had to do therapeutic graft for him. And in addition to topical steroids, we used topical cyclosporine for him. In the end, I would like to emphasize that we need to treat dry eye effectively with all the modalities available, including cyclosporine, before we subject these patients to surgery. On the left side, we have got a picture which was operated without treating dry eye. Patient developed endophthalmitis and finally got cystical. The other eye we treated effectively with all the modalities, including cyclosporine, and we had a good result. Now, in addition to the other effects of cataract surgery on dry eye, post-cataract surgery can also be aggravated by neurogenic inflammation. So we need to use cyclosporine in these patients pre-operatively also and for post-operative period also. And we need to control neurogenic inflammation. In some of the recent studies, they have used topical steroids pre-operatively so that we can cut down the inflammation post-operatively and we can decrease the effect of cataract surgery on dry eye. In the end, I would like to summarize that inflammation is a key mechanism in the pathophysiology of dry eye. Irrespective of etiology, chronic subclinical inflammation is crucial in ocular surface damage. Long-term treatment of ocular surface inflammation is of paramount importance to preserve the ocular surface and to prevent the visual loss. Cyclosporine A is effective in reducing the signs and symptoms of dry eye and also adverse effects of inflammation on the ocular surface. Thank you so much for your patient hearing.
Yeah, thank you, Ashok, for a good summing up that behind every successful dry eye, there is a spouse called ocular inflammation lacking. We'll now go on to the next presentation, which is by myself on management of dry eye. So our basic management strategies have changed a little after News 2 came out in 2017, and we learned a lot from them. Earlier also we had a structured way of doing it, but it became a little more structured as Srini has made the job easy by alluding to this. So basic aim of the management is to achieve homeostasis of the tear film and alleviate ocular discomfort. Obviously, patient is not interested in homeostasis. He doesn't understand the meaning of the word. He wants his ocular discomfort alleviated. For this, we need to know the cause first. And then we have a 4-stage management algorithm. After Srini's explanation to you about the necessary investigations and classification into evaporative and aqueous deficient, or predominantly evaporative or predominantly aqueous deficient, we then come to a 4-stage management algorithm, which gives a stepwise approach for approaching these patients. So there is a step 1, step 2, step 3, and step 4 approach that we do. As I said, after you've classified the patients, what are the treatment options that we have? We need to look at, besides looking at the eye, maybe we need to pay some attention to dietary modifications. These patients sometimes need to drink more water. To produce water, you do need to have a sufficiently hydrated body, and your cells need sufficient hydration. Ashok has alluded to anti-inflammatory therapy, which plays a big role, especially in your aqueous deficient dry eye patients. And of course, you need to use lubricants as treatment for tear insufficiencies. You need to replenish those tears. Everything that you do is not effective if your lid is not blinking well. So if there is entropion, ectropion, or an issue with the improper closure of the lids, you need to address this so that the tears, as Srini said, not only disperse like the windshield wiper across the eye, but also there is a tear clearance to allow good, healthy new tears to come in. And sometimes you need surgical approaches. So it's a multidisciplinary sort of approach to the management of dry eye. But let's talk about the main thing, which is for the general ophthalmologist, is the treatment of the tear insufficiency. So there are 3 ways of tackling this. One is tear replacement. So what is lost, you replace. If the by artificial tears, lubricants, it could be aqueous supplements. Hopefully in our country, supplements in a short while. And sometimes it could be biological supplements when nothing else works, like autologous serum, maybe 20%, 25%, which you can get your eye bank to make for you, or your blood bank to make for you. Our eye bank makes it for us. Then you need to conserve the tears which are already there. You're assuming that the tears are good quality. So typically I would do a tear conservation in an aqueous deficient dry eye when the patients have been on cyclosporine for at least 2 to 3 months. Then I check with dissolving punctum plugs, which are collagen plugs. And if the patient feels a wow factor in a day or 2 after you put those collagen plugs, then you know that his tears are of good quality and the permanent plugs will help. Dr. Kazu Subota, who himself suffers from dry eye in Japan, introduced me to moisture chamber spectacles, where he uses those tight-fitting glasses which can retain the moisture in the eye. Little uncomfortable, they look a little funny to wear, but they do work. And of course, now we've got new things in tear stimulation. We always had oral pilocarpine as a tear stimulant, tear producer. You have topical secretagogues. And now you have nasal neurostimulation by 2 methods. One is something being pushed into the nose to stimulate the nose, and finally it not only improves reflex tearing but also basal tearing. And then there are external gadgets which sit outside the nose, which also stimulate the nose. So this is something new we learned after DEWS 2. So artificial tears remain the mainstay of treatment, and there are all sorts of artificial tears in the market. The good news for all manufacturers of teardrops is that DEWS 2 very categorically said that there is no real superiority of one over the other, and very few randomized clinical trials have actually compared and come out, because it's such a vast differences between patient to patient. So these are some of the teardrops that we have: CMC, HA, and combinations of these, and HP Goar and combinations with it, and HPMC is still there. You have osmoprotectants, tiny molecules that go into the cells and hold on to the water in the cells, like L-carnitine, betaine, trehalose to some extent. As I said, lipid supplements are not yet available. Hopefully we'll get them. And then all the drops contain some preservatives, some friendly, some less friendly, some inactives, which are used to stabilize the tear drops. So osmotic, we won't go into all the various ones, but you can use hypotonic tears were used and came in a big way, but they're really not very useful and have gone out of the window now. And of course, topical cyclosporine is what Ashok has spoken of. Anti-inflammatory can be either steroids or cyclosporine. To some extent, tetracyclines, especially when there's a lot of Meibomiatis involved in these. And there are some other newer products, biologics, which are showing a lot of promise. Dietary modifications, as I told you about, whole body hydration, restriction of alcohol intake that dries your eyes up. Many people don't realize this. Omega-3 and omega-6 fatty acid supplementation. There was the DREAM study, but there are limits which said that omega-3 is not as good as a placebo. But there are limitations to the DREAM study. It was with fish oil, and in our country, it's made with different other sources. So I still use omega-3 from time to time. So basically, there's a staged method. Your step 1 is inadequate. You can go to step 2, then step 3, and step 4. So step 1 is education of these people and eliminating the offending thing. If there's an air-conditioned blast coming on them, you can avoid that, and proper lid hygiene. And any teardrops is fine. In step 2, if it doesn't work, then you go for non-preserved tears. This is where you would use punctum occlusion. If you have access to lippy flow, in the case of Meibomitis, you would use this once maybe in 6 months or so. And the topical anti-inflammatory cyclosporine and lymphatic dust, when it's available in our country, can be used as well. In step 3, you might have to go for oral secretagogues, some autologous serum in a non-healing ulcers, and maybe some scleral contact lenses as bandage contact lenses with fluid in them. And in step 4, really, you're looking at surgical options like salivary gland transplants, tarsorrhaphies, parotid duct transplants, and in end-stage keratoprosthesis to improve vision. So the summary of management, it's important to find out the cause. A 4-step approach is what is recommended by DEWS 2. Here, conservation, supplementation, and stimulation. In fact, the stimulation part will come in a big way in the next couple of years, I feel. Thank you so much. And I apologize if I've carried coals to Newcastle and told you what you already know. I look forward to others lighting up the discussion with fresh ideas. Thank you so much. Srini?
Thanks, Quresh. I think that covers in a comprehensive way the management. Also, although, like you said, it is not a fast food formula. You can't just take one approach and apply it to everybody. So we have to basically look at the patient's findings and then do it. Is Nikhil here? He's back. Okay. So let's go on to specific subsets of dry eye now. You've given us a general overview of the options, but I'm sure there will be specific conditions where more details can be looked at. And Nikhil's here, he put together this session. So he's going to be talking to us on the post-cataract dry eye. Nikhil?
Thank you, Srinivas, sir. You can see my slide here now.
Yes, yes.
Perfectly visible.
Can.
Right. Basically, what I put through in this next couple of slides is a talk where I would talk about dry eye following cataract surgery, and also about ocular surface problems, especially epithelial and corneal problems, which are related to the dry eye, as I have seen in my practice as a referral. So at the outset, we need to understand that the incidence and prevalence of dry eye after cataract surgery is greatly underestimated, and it can vary anywhere from 10 to 35%. And I think we need to look at all patients undergoing cataract surgery to see whether they have any of these factors either before or after surgery. Unfortunately, most patients, you do an excellent surgery, but following surgery, after a few weeks, you suddenly find you've converted a happy patient into an extremely unhappy, irritated, and frustrated patient. And therefore, we need to look at what are the causes, the risk factors, how can we prevent it, what are the early diagnostic approaches, and what should we do to treat these patients. So some of the factors in the preoperative period may be, for example, elderly age, the presence of dry eye disease preoperatively, which may or may not be picked up by us, the presence of Meibomian gland disease, and the use of several drops preoperatively may add to the problem of the dry eye situation. During surgery, of course, we sometimes put a lot of drops. We might use large corneal incisions in some patients where the nerves are getting damaged, or we could do a longer surgery where the various factors dry out the surface and tend to cause problems. And in the olden days, we also had sutures, which would add up to some of these problems. Post-operatively, the use of drops with preservatives, antibiotics, and NSAIDs might further make things worse. So what typically happens in the post-operative period may be toxicity. This could be to preservatives, maybe antibiotics or non-steroidal anti-inflammatory drugs. And all these can give rise to ocular surface staining or might lead even to the development of an epithelial defect. We know that patients with dry eye are more prone to toxicity because of the delayed tear clearance, and these medications last longer on the ocular surface. The dry eye by itself can also cause epithelial damage. Similarly, we can have patients where there are neurotrophic factors, which could be either because of corneal incisions and cutting the nerves, or it could be because of systemic disease or previous treatments. The cornea may be anesthetic. There could be viral or some other etiology where the cornea is anesthetic or has poor sensation. These eyes are predisposed to dry eye because of a drop in tear secretion. And they also have healing problems because of corneal loss of trophic factors. Similarly, we could have some patients may have a subtle viral disease which could get reactivated and come post-surgery with surface problems and then into an epithelial defect. Patients with poor sensation more prone to trauma while putting drops, which might complicate things. And as I said, sometimes tight sutures can cause Dellen effect and cause dryness of the ocular surface. So can we really predict what is going on? So we need to see them preoperatively, at least beyond the cataract and before the cataract, start looking at the tear film and the ocular surface. We may not have all the time to do Shermers and significant amount of testing, but we need to look at specific clues. There are several high-end equipment like this. We do a lot of testing. However, most small practices neither have access nor have the time to do all these testing. So we need to look at simple things. For example, when you do your biometry, the keratometry Mayers are distorted. It should be an indicator that there's something wrong, or the presence of froth on the ocular surface, or the presence of meibomitis, how the glands express out when you squeeze them. So these are some simple clues that we must look when we do a cataract surgery workup. And if you have sophisticated equipment, you can do more sophisticated testing. We are all aware that preservatives can impact the ocular surface, make things worse in an eye with significant epithelial damage to the corneal surface with the use of these drops. And for early diagnosis, just like any other dry eye patient, we need to listen to the patient, look at symptoms that he is complaining to us, do a little bit of fluorescein staining, which can help us to pick up early staining, and then closely look at these patients to figure out what's happening. In most of these patients, once you pick up the problem early, you can always treat it quickly by stopping the preserved drop, stopping the non-steroidal or toxic medication, using preservative-free steroid drops, preservative-free lubricants, try to manage the MGD, and maximum you may require some oral doxycycline. And most of these patients with careful follow-up do pretty well if you pick it up early. So basically, when the cataract workup is done, we need to do a little bit of dry eye workup, which may be symptomatology, looking at the glands and the surface, and a little bit of staining. If you do pick up dry eye, I think we need to treat it before we do the surgery. If you pick up only risk factors in a given patient, no real dry eye, then maybe you need to be very cautious and monitor them more often post-surgery. If everything looks normal on the ocular surface, just go ahead and do your routine surgery. However, all patients need to keep monitoring for early symptoms, modify the treatment if you look at any or you find any early symptoms, and keep watching them a little bit more frequently. However, when we miss some of these early changes, we have a patient who walks in irritated and agitated, and there you have the dry eye situation with where you need to treat them a little bit more aggressively. This cycle of events happens in most situations, the cataract surgeon picks it up early where the patient complains of redness and irritation. So the surgeon would normally put more drops, tell him to step up medication sometime on telephone, only to find he's getting worse. So if the surgeon can pick it up at this stage and make changes in the treatment, the patient will usually recover quickly. However, in rare situations, the condition continues to progress. Sometimes antivirals are given, and the patient continues to worsen and then walks into the cornea clinic with an epithelial defect or a stromal melt. And then it's a little bit more difficult to manage these patients. And in these patients, again, we need to look at cautiously for an aqueous deficiency, for evaporative dry eye. Always look for corneal sensation, the list of medications that have been used in the past, whether there has been any trauma while putting drops, presence of any subtle scars, opacities, or an irregularity on the ocular surface which might predispose to dryness. Again, most of these problems can be treated just the way we treated mild cases. However, occasional patients might require that you need to look for infection, need to look for autoimmune conditions where you may need immunosuppression, look for corneal melting, and you might have to do a bandage lens or a tarsorrhaphy. So these are some of the more difficult cases that you will see as a cornea specialist in your clinic, which need a little bit more different approach. And sometimes it's difficult to figure out whether this is viral or not viral, and you have to take a decision as to how to treat them. This was just a patient who came in with tight sutures, a large epithelial defect, and you can see ciprofloxacin deposit. However, he recovered well once you realize the basic underlying pathophysiology. So in conclusion, I would,
doctor.
Yeah, in conclusion, I would say that preoperatively avoid too many preserved drops. Always look at the ocular surface and try to optimize it. Quick keys to look at the keratometric Myers, which will tell you a lot. Be careful while using topical antibiotics, non-steroidal anti-inflammatory. Delay surgery if you feel you're not comfortable with the ocular surface picture. During surgery, reduce the number of drops that you put or irrigate the surface. Use a viscoelastic on the cornea rather than using constant irrigation, and try to do surgery with a smaller incision. And be careful, especially in patients who have dry eye, if you want to use a premium IOL. Post-surgery, you can always use artificial tears. Whenever you feel there is a problem, avoid non-steroidal antibiotics, anti-inflammatory drugs, and epitheliotoxic antibiotics. Be cautious if you have especially done a premium IOL, because these patients will be very unhappy with the results once they have a dry eye problem. And whenever need be, see them more carefully and more frequently so that you can avoid getting into trouble. So with these few preventive steps, I think we can manage most of our cases successfully in practice, and we may not even need them to send them to a cornea surgeon. Thank you, all of you, for patient listening. Thank you.
Thank you, Nikhil. I think that pretty much covers most of the scenarios that we can see after a post-cataract when there's a surface problem. I think in continuation to this, let's go on to Dr. Hijab, who's again from Mumbai in her own practice after having a corneal training at LV Prasad. So she's going to be continuing what Nikhil probably said with some interesting cases of dry eye. Can I request Dr. Hijab to start her talk, please? Thank you.
Good morning, and thank you, Dr. Nikhil. Thank you, AIOS. I hope I am visible. So the first case is a young 25-year-old healthy male. He came to me with a large persistent epithelial defect. This was about sometime in 2016 with reduced corneal sensation. This resolved with lubricants and a bandage contact lens. And I thought it's a neurotrophic, metaherpetic ulcer. He came back in March this year with similar complaints, reduced corneal sensation, and this time he also had reduced sensation on that same side of the face. So I thought maybe I'm missing something. I sent him to a neurologist who then sent back a note to me that he's a known case of Hansen's disease, and he's got a recurrence at the moment, and he's already on multi-drug therapy. We sort of failed to elicit this history from him, and maybe he was shy to share it with us. We any which ways treated him with lubricants and bandage contact lens. Then I went and looked up this report, which showed that in leprosy, 43% of the patients can present with corneal anesthesia. Ocular involvement in leprosy can be due to direct mycobacterial invasion, causing keratitis, iritis, scleritis, episcleritis. It can affect the 7th nerve, causing lag ophthalmos, 5th nerve, causing corneal anesthesia, can lead to lid deformities like madarosis, trichiasis, entropion, and there could be affection also due to hypersensitivity reaction to the M. leprae antigen. Ocular manifestations of leprosy can occur despite getting cured microbiologically. which suggests a treatment duration longer than 2 years if the eye is involved. And leprosy prefers the anterior segment of the eye as the organism avoids the vascular choroid and prefers the cooler anterior segment structures. The bacilli can also directly infiltrate the cornea and the unmyelinated nerve fibers, leading to corneal hypoesthesia. There can also be beading of the corneal nerves in patients with high bacillary counts. There can be calcification of the M. leprae also appearing as beading, and it can be seen even after declaration of microbiological cure of the disease. So when to suspect leprosy? Whenever we see hypopigmented erythematous or hypoesthetic hairless skin patches on the malar area of the face, with the loss of sensation, a loss of eyebrows, loss of eyelashes, facial palsy, orbicularis paresis, and lag ophthalmos, we need to have a doubt of leprosy. The diagnosis of leprosy affecting the eye remains clinical and can be easily overlooked. Therefore, we need to have a high index of suspicion. The characteristic skin lesion with definite sensory loss without thickened nerves and a positive skin biopsy showing the acid-fast bacilli or modified carbol-Fuchsin stain is the gold standard for diagnosing leprosy. WHO in 2018 has recommended the use of 3-drug regime, rifampicin, dapsone, clofazimine for at least 6 months in paucibacillary and 12 months in multibacillary forms of leprosy to prevent recurrence. The lid management, lag ophthalmos, when it presents early, we could combine systemic steroids along with multi-drug regimen to limit the extent of neuronal damage and treat the ocular surface dryness conservatively with lubricants. However, more severe cases would require tarsorrhaphy and other oculoplasty procedures. The corneal lesions, one is anesthesia, the other one is interstitial keratitis, which will require topical steroids and systemic multi-drug therapy for resolution. Corneal anesthesia cases need to be monitored for development of persistent epithelial defects and secondary infections. Keratoplasty has been advocated for corneal opacities secondary to scarring following exposure and ulceration. Episcleritis, scleritis, iritis will require topical systemic steroids and systemic multi-drug therapy. So now the second case is a 39-year-old healthy male who came to us with severe dry eyes 3 months post LASIK. He was a contact lens wearer prior to surgery. He came with diffuse superficial punctate keratopathy and he was very unhappy with the vision. We treated him with topical lubricants and he also required punctal plugs for the resolution of his symptoms. So I just looked up literature and we all know that dry eye is seen commonly post refractive surgery. Symptomatically, patients do improve over 3 to 6 months. The creation of the flap and ablation of the corneal stroma damages the corneal nerves. It compromises the afferent sensory arm of tear secretion, decreases the quantity and quality of the tears, and decreases the release of the neuroprotective factors required for ocular surface health. It is seen commonly in the older age patients, female gender, deeper ablation depths, patients with a prior history of contact lens use, prior history of dry eye, connective tissue diseases, and a pre-op Schirmer's of less than 10. So we need to do a good pre-op evaluation before advising the surgery. In vivo confocal microscopy, looking at the nerve fiber regeneration, post-PRK showed that at 1 month, 19% regeneration occurred. At 6 months, 50%, at 2 years, 92%, and 10 to 20 years, the regeneration was comparable with that of controls who did not have any surgery. Post-LASIK, at 1 month, 11% regeneration occurs. At 6 months, 27%. At 5 years, 79%. So post-LASIK, the process is slower and less complete. It depends on the thickness of the flap and the ablation depth. Post-SMILE, the regeneration is at 1 month, 55%. 6 months, it is 58%. So SMILE does fare better than LASIK. The initial decrease in the subbasal nerve density is also less severe in SMILE at 3 months, but at 6 months, these authors found no great difference between Febto-LASIK and SMILE. Now, this was our third patient. She was a 16-year-old girl who came to us with recurrent episodes of redness, tearing, and photophobia. We can see the crust on the base of the eyelid margin, and you can see the conjunctival congestion. There is 360 degrees corneal vascularization, punctate keratopathy. There is peripheral infiltration in the cornea. A similar picture is seen in the other eye, but it's less severe compared to the right eye. This was a typical case of blepharokeratoconjunctivitis, which is frequently misdiagnosed. At 1 month post treatment with topical antibiotics, steroids, lubricants, and lid hygiene, she has recovered good vision, and the eyes have become much quieter. So patients with blepharokeratoconjunctivitis usually present with anterior blepharitis, posterior blepharitis, recurrent chalasia. The cornea may show pannus formation, subepithelial infiltrates, punctate keropathy, even flictonules, corneal vascularization, and scarring. These changes are usually bilateral but can be very asymmetric. It's more common in India, Sri Lanka, and the Middle East. The pathophysiology is less understood. It's a hypersensitivity reaction to the bacterial antigens, and it is often, it presents commonly around the age of 4 to 5 years, though it can present in the teenage years as well. In children, it is often misdiagnosed as allergy and a herpetic involvement, but we need to be very careful in these children because they are in the amblyopic age group. In refractory blepharokeratoconjunctivitis, one needs to have the differential of ocular rosacea and Demodex in mind because they will require a different treatment. Treatment is usually in the form of lid hygiene, warm compresses, topical antibiotics, low potency steroids, and for refractory cases, we may need to use topical cyclosporine and even tacrolimus. Oral azithromycin is a very useful adjunct to eyelid hygiene and topical treatment. It's got a much broader spectrum of action. 1 drop of azithromycin persists in the tear film for up to 6 days, and 1 gram single dose of azithromycin maintains an antimicrobial level for 14 days in the conjunctiva. Oral doxy can be used in older children who have completed their dentition. Topical cyclosporine may need to be given for at least 3 to 6 months. Low potency steroids also will have to be given for at least 4 to 6 weeks. Both the patient and clinician need to understand the complexity and chronicity of this disease. There is currently no established cure. We can only control the disease. I think, shall I continue with the last case or skip it?
Yeah, go ahead. So I think we have 1 or 2 minutes extra. Definitely.
Yeah, so this was the 4th patient. She's a 50-year-old female with bilateral redness, dryness, pricking since 4 years. No history of systemic illness, no fever, no skin rash, no reaction to any medication. And she's come with conjunctival congestion, both the eyes, superficial punctate keratopathy. There is cataract. There is no keratinization of the lid margins, no distichiasis. She had early symblepharon formation and there is phonacial shortening. So my differential for her would have been a mucous membrane pemphigoid, though she's only 50 years and she's having complaints since last 4 years at least. The other differential was mucus, mycoplasma-induced mucositis or some other viral infection which could have caused a mucositis. There's this excellent article by Dr. Jayesh Wazirani and colleagues in IGO November 2020, which has beautifully described all the causes of chronic cicatrizing conjunctivitis. Even when I went through this table, my patient just sort of fitted into the mucous membrane pemphigoid diagnosis and maybe a mucositis. And here, going through this flow chart, looking at the patient's symptoms, signs, and history, they have differentiated the different causes of cicatrizing conjunctivitis. We used topical lubricants, steroids. We took a rheumatologist's opinion. All tests were negative for autoimmune disease. Only HLA-B27 was positive. We started her on systemic immunomodulation. After the ocular surface stabilized, which took nearly 3 to 4 months, we did the cataract surgery. We gave her post-op topical steroids mixed in lubricants, gave her preservative-free antibiotic, did not give her any topical NSAID, and perioperatively gave her IV methylprednisolone. So whenever there's a doubt of mucous membrane pemphigoid, you need to do a conjunctival biopsy to rule out any underlying neoplasm and also to confirm your diagnosis. You need to subject it to immunofluorescence. You need to send the sample in special media such as Michel's medium, which becomes slightly tricky in a private practice. We are not in a tertiary eye care center. The immunofluorescence will show deposition of immunoglobulins in the subepithelial zone. The biopsy positivity rate is 50 to 86%, and it's better to take biopsy from both the conjunctiva and the mucous membrane to improve the diagnostic yield. In our case, the diagnosis was clinical. If we had a positive biopsy, it would have been great, but a negative biopsy would still not rule out mucous membrane pemphigoid, and we did not suspect any neoplasia. She responded very well to steroids, and we did do a systemic evaluation to rule out any life-threatening vasculitis or autoimmune disease. Thank you.
Thank you, Dr. Hijab. We'll have our next talk now, and I'll invite Dr. Swapna Shanbag. as we just heard, Hijab, this article on cicatricial dry eye. So she is one of the authors. So I think she's the best person who can guide all of us as to how we should really manage cicatricial dry eye. And so when we see one in the clinic, it's always difficult in practice to figure out whether we should do biopsy, whether we immunosuppress them, or this is old pathology. So, these questions come to the mind of every ophthalmologist. So my intention today for this talk was, one, to make people aware that this is a separate condition of dry eye. Just like we have autoimmune dry eye, we have cicatricial dry eye, which needs to be picked up early, and how to analyze these patients, and so that we optimally treat them in our practice. So I'll request Dr. Swapna, who is the consultant ophthalmologist at the prestigious LVPEI, to come and give her talk. Welcome.
Thank you so much, Dr. Nikhil. And thank you for inviting me to give this talk at this session. So cicatrizing conjunctivitis results in severe dry eye, end-stage ocular surface disease, and permanent corneal blindness. Now, why is it important to diagnose these entities early? Because in the chronic phases, they all look the same. They are indistinguishable. The treatment in end-stage disease is type 2 K-Pro, which is very difficult to manage, as we all know. And some of these conditions also have significant systemic morbidity. So for all these cases, it is very important to examine the tarsal conjunctiva very well, and also look out for this very characteristic subepithelial fibrosis on the tarsal conjunctiva, as can be seen in this eye. Sometimes it can be subtle, still significant. These are all cases of biopsy confirmed mucous membrane pemphigoid. And this is very typical, the lacy kind of fibrosis that you see in MMP. And second, we need to examine the fornices, especially the inferior fornix, because in this case, this is again a biopsy confirmed case of mucous membrane pemphigoid picked up very early. You can see the fibrosis here in the inferior fornix. This is not normal. You can also see medial and lateral canthal fibrosis. This is a bit more advanced than the last case. Again, should not be missed, can be very easily missed during our routine examination on the slit lamp. But I always make it a point to examine the inferior fornix in all cases, so that I know that when it is very subtle and I can still pick it up. Sometimes it can be only limited to the medial area. And again, examining the lacrimal gland is something we do not do, which is a bit not intuitive, because these are all cases of dry eye, and they're all because of some lacrimal gland pathology. So it's very important to examine the lacrimal gland, something even we have learned in the last 1 or 2 years. So in the upper images, you can see these are all normal lacrimal glands. They are pink, they are very convex in shape. They prolapse out when you retract the superior-temporal eyelid. And these are cases with a normal Schirmer's, as can be seen here. However, these are cases of cicatricial dry eye, MMP, and SJS. You can see there is fibrosis here. The lacrimal gland is not pink, convex. And there is a synechia here in the area of the lacrimal gland, which corresponds to what the Schirmer's is in this eye. Again, complete fibrosis, cannot see the lacrimal gland clearly. Schirmer's is 0. Here, there is one normal area. The rest of the gland is fibrosed. Also, it is it's very beautiful to examine the tearing that happens from these lacrimal glands. You can just use a fluorescein strip placed here when you're looking at the lacrimal gland on the slit lamp. And in normal cases, you see about 2 to 4 ducts which are actively secreting tears. And these are seen very beautifully. However, in cases of cicatricial dry eye, as you can see here, there are no ducts releasing these tears. So we have published this last year in 2 papers in the British Journal of Ophthalmology. In one, we have described the anatomy of the normal lacrimal gland and how to examine it in normal versus dry eyes. And in the second, we have described the tear secretion from the lacrimal gland. So I'll be discussing 2 cases and mainly to show what are the most common cases of cicatricial dry eye that we see in our clinics. So this was a 76-year-old female from Hyderabad, housewife. Came to us with left eye irritation, foreign body sensation since 2 months, diagnosed previously as dry eye disease, and was only on lubricants. As you can see here, the lid margins are rounded. The lid margins did not have any other pathology other than Meibomian gland disease. However, she had this very strange medial canthal shortening or fibrosis. She had very subtle tarsal subconjunctival fibrosis on the tarsal conjunctiva, as can be seen here. And again, very subtle fibrosis in the inferior fornix and some folds that could be seen and some amount of shortening. When we stained the ocular surface, there were diffuse SPKs all over the cornea. The Schirmer's was 3. So the provisional diagnosis in this case was a left eye chronic cicatrizing conjunctivitis, severe aqueous deficiency dry eye with pseudophakia. Now, like Dr. Hijab alluded to, this was a paper we have published in IJO last year, where we have discussed all the differential diagnosis of chronic cicatrizing conjunctivitis. So there are multiple causes, and we slowly need to find out how to rule out all these causes because they all present in the same way. This is a beautiful series of images from Dr. Dart's very seminal paper on cicatricial conjunctivitis, where the findings are the same in all these eyes. However, the etiology is different in every single eye. So it shows us there is so much that we need to rule out in these kind of cases, and it can belong to any one of these entities. So coming back to the algorithm that Dr. Hijab showed from our paper, we asked all these questions to the paper and to the patient, and we ruled out all these common etiologies such as thermal burns, chemical burns, radiation, GVHT, drug-induced cicatrizing conjunctivitis, pemphigoid rosacea. And we finally came to the important question of, is there any history of skin or mucosal involvement in the past? Now, this patient did not give any history of skin or mucosal involvement, which can still be mucous membrane pemphigoid or some other autoimmune entity. So we did a serological profile, which all came back negative. RA factor, ANA, both were negative. And then we decided to do a conjunctival biopsy. We take a biopsy from both eyes, and we send the biopsy to both histopathology and diffuse immunofluorescence. Michel's transport medium is something that can be used probably in private practice because logistically it might give you more time to send it to the pathology lab. And on immunofluorescence, we typically see this positivity at the basement membrane because of deposition of immunoglobulins and complements. So her biopsy was positive, and the final diagnosis was mucous membrane pemphigoid. The right eye was perfectly fine for this patient. About 20% of cases of MMP present only with unilateral involvement. However, we have to keep a close watch for the other eye also. It may soon develop the same condition. So the treatment was mainly, this algorithm is again given in our paper. And because this is progressive cicatrization, the main treatment here is systemic immunosuppression. So we did baseline investigations and started her on oral cyclophosphamide. Very important to even counsel these patients as to why you're doing this, because in early cases, they do not have that many symptoms, but you have to sit with the patient and actually tell them what is happening, what might happen in the future if you do not start oral immunosuppression, and the possibility of corneal blindness. We closely monitor the ocular surface on every 3-month visit, also do blood investigations every 3 months because she's on systemic immunomodulators. And we treat it with topical lubricants, mainly topical steroids only if required. This is Foster staging system. So in stage 1 and stage 2, these are the main stages where we need to pick up these cases rather than let them progress to stage 3 and stage 4. This is a typical case of mucous membrane pemphigoid, came to us in the acute phase with bilateral cicatrizing conjunctivitis, typical palatal ulcer, oral lesions on her skin. But this is rare. We do not see such typical cases of mucous membrane pemphigoid because they do not come to us sometimes in the acute phase, and they come to us multiple years down the line. So very important to pick this entity up early. So history taking slit lamp examination is extremely important, and we should always practice a low threshold for conjunctival biopsy, especially when it's possible in a tertiary center like ours, to prevent cornea from going from this to this. Now I'll talk about case 2. So this was a 36-year-old female from West Bengal, both eye blurring since 12 years after an episode of chickenpox. As you can see here, the right eye is more affected than the left eye, but she has this pillar-like foreshortening in both the medial and the lateral canthus. She has, the lid margins look grossly normal with no keratinization at least, although the Meibomian glands are completely blocked. And the inferior fornicial shortening is very gross. She has LSCD, corneal vascularization, dystichiatic lashes, and as can be seen here. Schirmer's is 4 in this eye. Left eye, again, very similar findings, but the cornea is much better. And the Schirmer's is 5 in this eye. So again, a diagnosis of chronic cicatrizing conjunctivitis. with right eye partial LSCD. Again, we went to the algorithm, asked for all the history, and she gave history of skin and mucosal involvement with hospitalization about 12 years ago. And then we do something that we have formed, which is the Sjs Scoring. This is again published in the British Journal of Ophthalmology last year. And what we do is we take a very good medical history and we do a very good clinical examination to mainly come to the diagnosis of Sjs. So skin discoloration, disfigured fingernails or toenails, posterior migration of the mucocutaneous junction, lid margin keratinization, dystichiasis. All of this gives us 1+1 point in the scoring system, and medical history is again important. So in the medical history, if the patient gives history of sudden onset of conjunctivitis associated with peeling of skin on pressure, associated with loss of nails in the acute phase from the fingers and the toes, with hospitalization for a long time during this episode, these were all the history that the patient gave us. And with clinical examination, she had disfigured fingernails and toenails. She had posterior migration of mucocutaneous junction in the mouth, no lid margin keratinization, but she had dystichiasis. So for her, the scoring came to +7. And if it is more than 5, we come to a diagnosis of Stevens-Johnson syndrome. If it's less than 5 or equal to 5, we tend to go towards the diagnosis of mucous membrane pemphigoid. Now, because she is Stevens-Johnson syndrome, we do not do a conjunctival biopsy in these cases unless there is a clinical suspicion of something else happening. And at the same time, what is the treatment algorithm? Because she did not have lid margin keratinization, we did not do a lid margin MMG, but she has dryness and keratopathy, for which we do give scleral contact lenses. So scleral contact lenses, we were unable to fit in this eye because of fornicial shortening. And that's why we did mucous membrane grafts over the bulbar surface. And then there is scleral lens fitting after 2 months. And now the patient is very comfortable. So again, history taking, general examination, slit lamp examination, scoring systems are all very vital to reach an etiological diagnosis. This was a case where somebody...
Sorry to interrupt, doctor.
Yeah, I'll be just finishing.
We are running very short of time.
Yeah, so this was a case which presented to us having undergone symblepharon release and AMG elsewhere. And this was actually a case of MMP, misdiagnosed as herpes. And this went on to become this. So we need to be very good at diagnosing these disorders. So again, detailed history taking, meticulous clinical examination, complete autoimmune workup, conjunctival biopsy, and evaluation for systemic involvement to initiate immunosuppression is very important. If any doubt clinically or an equivocal Sjs score, then a conjunctival biopsy should be done in these cases. I have a few slides on treatment, which I'll not allude to because this has already been covered. I would like to thank my colleagues and the ocular surface team at LVPI. Thank you so much.
Thank you, Dr. Swapna. It was a nice talk, very comprehensive. Our next speaker today is Dr. Bhaskar Srinivas, who is a consultant and faculty at Shankar Nethralaya and who does a lot of work in cornea, ocular surface, keratoprosthesis, and a lot of niche work which is possible only in the large institutes with very high volumes. And I wanted him to speak today on autoimmune dry eye, because when we see patients of dry eye in clinic, we need to segregate this subgroup of patients so that they can not only get rheumatology referrals, but they can also be sort of treated more aggressively because they behave so much different than our routine computer vision syndromes and those normal dry eye patients that we get. So I'll request Bhaskar to go ahead with his presentation. Dr. Bhaskar, please.
Thanks, Nikhil. I'll just share my slide. Yeah, so I've been asked to speak on autoimmune dry eye. No financial disclosures here. So basically, when you're talking of autoimmune dry eye, I'll be restricting myself to primary or secondary Sjogren's. Now, these are eyes where you will normally have an associated Sika syndrome. You might have an associated chronic fatigue. You might have systemic involvement where it becomes a secondary Sjogren's syndrome. So the most important thing when you are looking at a dry eye patient is a detailed history. You need to ask them whether they have dryness in the eyes, whether they have dryness in their mouth, whether they have joint pains, any skin rashes, any drug history, any weight loss, cough, hemoptysis, any issues with any neurological dysfunction. So history taking is very important. Based on your history, you will have some idea if there's any systemic issue with the patient and you need to evaluate the patient more. Coming to the clinical diagnosis, at this point of time, the primary Sjogren's, according to the European and the American consensus, based on the salivary flow, the abnormal Schirmer's less than 5, the lissamine or the fluorescein staining more than 5, an anti-row, and a histology. But of all the ocular findings, they gave only 1 point to both the Schirmer's and the fluorescein staining. So unless you actually do a biopsy or you do a blood test for a row or an SSA, and that becomes positive, it will become a little bit difficult for you to actually label it by yourself to say that it is a primary Sjogren's. If you have any of the blood investigations which is positive in terms of other collagen vascular diseases, and you have a dry eye and a dry mouth, it becomes easier. So the best way would actually be to refer these patients. If you have a very low Schirmer's, you have significant corneal staining, and you have a history of dry mouth, it is better to refer the patients across to a rheumatologist, let them do a detailed evaluation, and then they will give you a diagnosis whether it is a primary Sjogren's or it is a secondary Sjogren's. When you're looking at secondary Sjogren's, even though ophthalmologically we probably see a lot more of RA patients with secondary Sjogren's, if you ask the rheumatologist, they will say that SLE is more commonly associated with secondary Sjogren's, with almost about 36% patients developing secondary Sjogren's. Again, you have to exclude other cases and exclude any other potential disease which could be a masquerade. So why do you need to be aware of this, and what do you want to do when a patient comes to you? Obviously, just using a drop of fluorescein on the eye gives you a staining pattern, and this tells you that the dryness is much more severe than the routine computer vision syndrome, and you need to take this patient a little bit more seriously. Again, a fluorescein test will tell you not just the staining pattern, it will tell you the amount of tears with respect to the tear meniscus. It tells you how much the tears flow as the lid blinks. That gives you an indirect assessment about the amount or severity of the aqueous deficiency, even if you don't have the newer diagnostic tools to estimate the TMH in terms of millimeters. You would need to have a rheumatological consultation, even if you are basically trying to see if these patients require cataract surgery or any other intraocular procedure, because you need to be clear that your surgery is not going to cause them any problems in their postoperative period. So this patient, I'll go through certain cases. This patient presented to the OPD with decrease in vision in the right eye, and she wanted cataract surgery. The right eye looked reasonably okay clinically. The fluorescein staining was also not bad. The meniscus was also good. But look at the other eye. The other eye has a much worse staining. The tear meniscus is on the lower side. And if you look at her hands, they show deformities of chronic RA. So it is important to examine the patient systemically. Any patient with a dry eye, specifically look at the joints, ask them the history for you to come to a diagnosis as to what could be the cause for their dry eye. And why are we worried when you're talking about a cataract surgery in these patients is because you can have an altered microbial flora in their eyes. So you could end up with a little bit of increased risk of infection. You might have issues with IOL calculation. You might have issues with visibility during surgery. So you need to plan a lot more. Also, preoperatively, you might want to address the lids, make sure that there is no blepharitis, which is going to worsen your prognosis post-surgery. And you would want to try to correct the dry eye status as best as possible before you actually go ahead with the surgery. It would be preferable to get what is called as a DAS28 questionnaire, which the rheumatologist will be doing it, whether it is with CRP or ESR. And you would want to plan surgery only when the disease activity is low. So this patient presented with severe dryness with a completely +3 staining of fluorescein on all the 3 areas of the cornea, and wanted cataract surgery. So we first did a cautery because the Schirmer's was 0, and then after almost about a 3-month period, she underwent cataract surgery. Another patient with a very severe Sjogren's with a very low Schirmer's, low TMH, absent reflex secretion on fluorescein clearance, using lubricating drops every hourly. You cannot go ahead and do a cataract surgery directly in this side. That is inviting disaster. So you would improve the ocular surface by doing a cautery, because when the Schirmer's is 0, even your cyclosporine and other medications might not work. You will have to do tear retention methods to improve the ocular surface health. Intraoperatively, when you're doing a cataract surgery in these eyes, there is always a debate whether you would want to do a scleral incision versus a corneal incision. We still do not have clear-cut answers, but suffice to say that your incision should be as small as possible, and your threshold for taking sutures, if there is any doubt of leakage, should be very, very less. You would want to hike up the lubricating drops in the postoperative period. You would want to defer NSAIDs. You would probably prefer a preservative-free antibiotic in the postoperative period. You could consider autologous serum or topical cyclosporine in the postoperative period if the patient can come for follow-ups and is clear about maintaining the autoserum tears in a hygienic manner. So coming to certain other cases, so this patient was a 50-year-old patient who came with decrease in vision with mild discomfort, irritation in the eye. So if you look at the fluorescein stain, the corneal is not staining as much. The tear breakup was around 4 seconds. The TMH value, even on fluorescein, looks a little bit low. And when we investigated her further, the NIBU2 shows a value of around 3 and 5, and the TMH is significantly low. She was positive for RA. The Sjs was around 5 and 7, and there was reflex tearing which was present. So we started her on lubricants and cyclosporine and sent her to the rheumatologist to start her on medications for the RA. Her lipid view also showed a little bit of a low LLT values. So even in Sjogren's or non-Sjogren's patients, you tend to have an aqueous deficiency first, which then gradually progresses. So you might have a component of lipid deficiency also. So you need to evaluate the Meibomian glands also in these patients. Another patient who presented with severe photophobia, severe filaments in the eye, unable to open the eye, and the Sjs value was 0, with severe inflammation. She was already on cyclosporine, on steroids. She was already under the care of a rheumatologist for her RA. So since the dryness was very severe, and in spite of steroids and cyclosporine, the inflammation was not coming down, we did a cautery for her. Post-cautery, she improved. For the filaments, we also gave her acetylcysteine. She did well for about a 2-week, 3-week period. And then she came back with a redness in the left eye, and you can see the sterile infiltrates and the peripheral thinning in the eye. This actually indicates a systemic worsening. We referred her back to the rheumatologist, asked him to hike up the systemic immunosuppression in terms of systemic steroids and hike up the methotrexate, which he did. And you can see the condition kind of getting better. She is now maintained on methotrexate. She has occasional episodes of inflammation, which gets managed with topical steroids for a short course of time. So it is important to understand that peripheral corneal melting, thinning, sterile infiltrates, scleritis, all these indicate that your systemic condition is not under control. And you need to be very clear to the rheumatologist that you want them to increase the systemic immunosuppression, because otherwise their eye will go for a toss. Another patient who had severe dry eye underwent cautery. She was under the care of the rheumatologist at that point of time. Then had a cataract surgery. He was doing fine. For whatever reason, she decided to stop her systemic medication. She ended up with a perforation, which sealed by itself as an adherent leucoma. And then the disease activity worsened, and we had to shift her from to HCQ, and then even that was not working. So then she had to be put on tofacitinib at this point of time. So it is important to talk to them that they cannot stop their medications unless the rheumatologist tells them. So it is important to have a detailed conversation with these patients regarding their eye and their systemic condition. Again, another patient who's actually a staff of ours who developed bilateral peripheral melts, thinning, corneal edema, sterile infiltrates, and in fact he worsened in the second eye. In spite of being on maximum topical and systemic medications in the first eye, we had to give him systemic cyclophosphamide, and then gradually it kind of stabilized. So when you're seeing peripheral corneal melts, thinning, corneal edema, large defects which are not attributed only to the dryness, then you're looking at a worsening of his immune status, and you will need to get back in touch with your rheumatologist to hike up the systemic immunosuppression in these patients. So this patient, a patient of RA who presented with a perforation. I don't have the first picture. She underwent a patch graft in this area, and then she also had this pterygium, subsequently underwent a pterygium excision with a conjunctival autograft, and then she underwent a cataract surgery, maintaining about 6/24 vision with spectacles. With the contact lenses, her vision is improving to 6/9, but she's a 60-year-old lady who doesn't want to wear contact lenses. Another patient who's a one-eyed patient, other eye is NPL, presented with these peripheral melts, thinning, not amenable to systemic medications. She had a cardiac issue, so we couldn't even do an amniotic for the defect and the melt. So we just decided to temporarily use cyanoacrylate glue at least to stabilize the eye so that we don't end up with a perforation. And once her systemic condition got better, she underwent a cataract surgery subsequently, regaining 6/9 vision in that eye. Again, this is one of the last slides. When you have an RA patient with systemic involvement, with scleral thinning, with peripheral corneal thinning, and the patient comes with a total cataract, then your surgery becomes a lot more challenging. You need to decide whether you would want to go for a scleral incision, a corneal incision, or you would want to support the peripheral cornea using a rim of tissue first and then do a cataract surgery. So to conclude, in very severe ADD patients less than 5, always rule out an autoimmune disease. Refer to the rheumatologist or internist whenever you're seeing a Sjs less than 5 and you're having a history suggestive of dryness of the mouth or systemic complaints. You explain the ocular condition, not just to the patient, but also to the rheumatologist, because we want them to know that we want them to control the disease activity, or we want them to give us a clearance for surgery. And you would want the clearance for surgery only when the disease activity is low. And we would need to monitor the side effects of some of the medications that they use in terms of HCQ, where you would probably want to do a HVF 10-2, SDOCT, multifocal ERG or fundus autofluorescence, and inform the rheumatologist in case there are macular changes which come in, because they would need to switch the medications. I would acknowledge my team at Shankar Nethralaya, and thanks, Nikhil, for the opportunity.
Thank you, Dr. Bhaskar. It was a nice talk. I'll request Srinivas if we can have the question answer, we can moderate them.
Maybe we can ask Bhaskar and Swapna itself because he completed the last talk. Bhaskar, many times the rheumatologist ends up telling you that the patient's joints are all well, that they don't find much activity, whereas in some of those patients, the eye does have problems. So like you said, there is often a correlation between the systemic activity and the corneal melting or tectonic instability, but sometimes we have corneal problems when the patient is systemically, technically stable. How do you then address this issue of asking the rheumatologist to help us systemically treat the patient when they feel they don't need to?
The problem is the rheumatologists go according to the DAS 28, which basically is only on joints, that also on the upper limb alone. The ophthalmic formulation, ophthalmic manifestation doesn't come into their systemic grading of their severity. So that becomes a moot point of contention. So it becomes easier to actually call up the rheumatologist and have a one-on-one, or maybe just have so in terms of in Cara Connect, when we had a rheumatologist coming across, because they need to understand that when we are dealing with a sight-threatening condition, we need to hike up the systemic immunosuppression. We could start the immunosuppression ourselves, but then they are patients who have multiple systemic issues, and we would probably not be the ideal people to start medications on them. So it is always better to have a rheumatologist or an internist who understands your thought process, and you're telling them that we want it because there is a worsening of the eye situation. Because your ESR, CRP, none of the parameters can be used as a marker for worsening as such. They just use that as one criteria, and then they primarily only look at the joint assessment to decide on their severity. So you will have to sit across with your rheumatologist and convince him to use the to hike up the medication.
Swapna, the consent that we need to take for putting these people on these potentially toxic medications, do we do that, or does the rheumatologist do that?
For very cases where we need probably IV cyclophosphamide, oral cyclophosphamide, we do send them to the rheumatologist because these are very toxic drugs, lots of side effects. So probably would be handled better by a rheumatologist. But for early cases, like the immunosuppression regimen given by Dr. Dart, so for early cases, they generally start dapsone or methotrexate, and then the next in the flowchart is mycophenolate or azathioprim, and then comes oral cyclophosphamide. So in our setup, we actually do give methotrexate, azathioprim, and mycophenolate on our own. But for advanced cases, we do send them across to a rheumatologist.
Do they sign an informed consent that they've been informed of all the side effects for methotrexate, for example, or you don't take an informed consent specifically?
We do have an informed consent form. That's very important.
Recently, I had one patient, Srinivas, where I sent them to a rheumatologist, and he had started mycophenolate with low-dose steroid. The patient had a pneumonia and he was in ICU, and he was sick, and there the physician, the first thing he said is that your treatment which is going on is the cause of the pneumonia and you're immunosuppressed. And he came back to me after a few weeks. Once he has recovered, of course, I was in touch with him, but it's a very difficult situation now. He asked me again whether I should get immunosuppressed, or how do we treat the condition. So we were wondering whether we can use topical tacrolimus or something else, and sort of so it's very important to counsel these patients. Sometimes I find that we send them off with a lot of treatment which can be quite dangerous in elderly population. So we have to take that responsibility of educating them before we start the treatment. And I find a lot of patients extremely hesitant to start this treatment, especially who have a very minimal amount of early stage disease. They don't realize the importance that it might progress or things like that.
If I could just add a point.
Yes, please. Yes, go ahead, Bhaskar. Go ahead.
I mean, when you're looking at RA patients, yes, sometimes you might have episodes of inflammation, ocular inflammation, where topical steroids, topical tacrolimus works. But obviously, if you're going to reach to a stage of PUK, or you're going to reach to a stage of scleritis, you don't have a choice. You have to go for systemic immunosuppression. Whereas with OCP, you probably want to go ahead for systemic immunosuppression early. The problem in OCP is if the patients are not as uncomfortable in that phase, and you are picking it up and telling them that there is this possibility, they don't understand that they will go downhill till they actually reach a stage where it affects their vision. So convincing the patient in OCP in an early stage, where you have a very subtle fornic shortening, that they need systemic immunosuppression and these medications are toxic, becomes a little bit of a challenge.
Just as a continuation to this discussion, a number of these people who are now very stable on rheumatoid or OCP or on medications, they want to know whether they have to stop these drugs before they take their COVID vaccines. What are you telling them?
We're not asking them to stop, asking them to continue. There's no.
I think
unless they actually get a COVID infection, then it becomes the purview of the infectious diseases person. But if they're on it and if they're otherwise systemically well, yes, I guess we just tell them to take the vaccine and we don't stop it.
The only thing is we do not know whether the vaccine efficacy will be reduced because they're already on immunosuppressants.
We're learning. We're learning. Can I ask Hijab? Hijab, when you do tests for these dry eye patients in your clinic, is there a particular order that you follow that you suggest would be ideal?
Yeah, so normally we try and do the non-invasive breakup test because we have the series. So we do that first. Then we do the Schirmer's test. Then we do the fluorescein breakup time. And after that, we've already instilled fluorescein. Then we look at the staining like that. So we don't have access to measuring the tear osmolarity and also the MMP9. So these are the basic things that we do. I don't always do mammography because, I mean, unless I really suspect Meibomian gland disease, we don't do it for like everybody.
Okay.
These basic things.
So non-invasive first, and then so it's not good to do the Schirmer first because wherever you abrade the conjunctival surface, that's going to pick up the stain and interfere with your later diagnosis. Yeah.
Correct.
Now, is Quresh there or is he?
Yeah, I'm here. I'm here.
Hey, Quresh, you talked about the treatment. Cyclosporine, there are a number of variants on the market. There are those that come in multi-dose containers. There are unims and so on. So how do we decide which one to use? Are they all the same or do you have any guidelines as to how you could choose them?
Yeah, now a lot of newer drug delivery systems are showing promise. These nanoparticles, nano emulsions, what they call, which are supposed to penetrate better. The market leader, Allergan's Restasis, is still holds good with the unims. The problem is that not everyone is happy with unims and with the burning and sticking of the cyclosporine, while the multi-dose preparations seem to be more tolerated and are also easier to carry around. So I have switched quite a few of my patients from the Restasis to the multi-dose preparations, the nano preparations that are there. Only time will tell whether they are as effective as the companies claim they are.
Dr. Rao, can I say something?
Yeah. Yes, please.
I think very rightly said by Dr. Quresh that most of the preparations which we are getting in the market, they are basically aqueous preparations. And the problem with the cyclosporine is that it's not soluble with like aqueous base. And we need basically oil base, like castor oil. We used to prepare it in castor oil long time back. But the problem in castor oil is that it's very irritating. Even in the aqueous solution is also irritating. And the surface absorption of the cyclosporine molecule will be higher if you get very high concentration at the interface. And that we can get only if we have got an emulsion. And emulsions we know are two types, like it can be oil in aqueous or it can be water in oil. So for cyclosporine, we need oil in water emulsion. And technically speaking, that preparation is only with the allergen. I agree that patients are uncomfortable with it because of the cost also. And the more problem is that sometimes it's the availability problem, it's not available everywhere. But I think the one drop of the Restasis gives us 75 million micro droplets. The unique, the preparation is like that. So that is the reason it can help or it can get absorbed at a very low concentration also. It's effective at a low concentration also. So that is the technical point. But the problem is that even if we start a patient on Restasis, when the patient goes out to the referring ophthalmologist or somewhere else, they say, why are you using this one? Use this one, this is equally good. So that is the technical problem.
Cost is a consideration. Tacrolimus ointment is quite cheap and it's quite plentiful. So this is a question to everybody on the panel. In this situation where we are dealing with the inflammation, T-cell mediated stuff on the ocular surface and a chronic dry eye, do you have any comments or experience with the equivalence of tacrolimus vis-a-vis cyclosporine? Do they both work equally well or Maybe Bhaskar can start and then we can go through the others if they have any additional points.
Given a couple of patients who were not able to tolerate cyclosporine, but they felt that as long as they were using it, they felt a little bit better. And once they kind of stopped it, they were not as comfortable. The advantage of cyclosporine also is the fact that it has the oil base, so it adds on to the lipid layer of the tears to a certain extent, and that is why, in fact, they launched it as refractory in the US market at that point. That benefit might not be there with the tacrolimus ointment per se, and you might have a slight blurring, which is more prolonged if you're going to be using it in the morning. If it's only going to be using it once at night, or you ask them to use it on the lids in the morning and see. But the numbers that we have is in double digits. So I don't think we have clearly analyzed the benefits. You probably need to do that on a much more scientific manner and see.
Yeah, I've been using a lot of tacrolimus, but that's mainly for my allergy patients, not for my dry eye patients.
Swapna, any thoughts?
Yeah, so again, experience with tacrolimus is only limited to allergy patients who also have some complaints of burning, but I give it only once at night time. Mostly for all the dry eye cases, I do give cyclosporine, and patients do come back saying that's a lot, like they have stopped it and they've come back 1 month later saying they just could not tolerate it. But head to head, yeah, I do not have that much experience.
Any reason why we cannot use it, given the fact that they both work on the T cell? I'm not aware of any major differences in their method of action which may negate one or the other. So I'm just asking this, is there anything that prevents us from using it? Anything wrong about it based on the pathogenesis of the inflammation?
I don't think so. It's just that in evidence-based literature, we do not have a lot of evidence for tacrolimus in dry eye compared to what we have.
Maybe it's time for you and Bhaskar to run the study then.
In fact,
and let us know which one.
Yeah.
There are a couple of...
Sorry to interrupt, doctors, but can we please wrap up in a minute, as it is 12:28 already, and we only have a minute for the discussion.
Okay.
Thank you. Nikhil, do the honors. Thanks.
Yeah. So I thank all of our speakers today for a very excellent presentation, and then we have a very lively discussion. I would thank Dr. Srinivas Rao and Dr. Quresh Maskati, Dr. Ashok Sharma, Dr. Hijab Mehta, Dr. Swapna Shanbag and Bhaskar. All of us had a very good, interesting session on dry eye. And I think we missed Dr. Parul Deshpande, but it's for another day. I hope the audience found our discussions useful in their day-to-day practice and will help all of us. Thank you once again, and goodbye.
Thank you, Nikhil.
Thank you.